you bought that you loved?
Oh, you like that? I was just using it yesterday. What is the name of it? It's called Movi, Movavi, the Movi editor.
Oh, Movavi.
MOV, yep, Movavi.
Okay, that's an editing program.
Yep. I made a video. Actually, if you guys want to do it, send me a little, a minute or less of you guys talking about what you're gonna talk about at the conference.
Okay.
And you can do 1 minute for one and 1 minute for the other, and I'll put them into a quick promotion.
Oh, okay. Okay.
Happy to do it. So you just create it with your phone.
Okay.
And video, or if you could even record from your laptop. That's what one person did.
Okay.
Right from their laptop, and
All
then I take it from there.
We will get that to you next week. That's great.
There was a good one. I'll send it to you. Let's see.
So can you see my screen?
I can.
Yeah.
Okay. And let's make sure I can advance it. Yep. Okay. We don't want any of those things to go wrong.
Now, Leslie, do you know how many people are signed up on these, or do they?
For today,
Yeah.
54.
54. Good. That's good.
They might not all come in, or I might get extras, but when I just checked it was 54.
Right.
And did you ever get the evals back from the, I can't see the toilet seat one, the visual?
Yes. Did I not send this to you? I'd be happy to.
Okay.
I do them. I pull down all that information twice a month from all the modules. It's a lot of data points.
I bet it's gotta be enormous.
It's we've trained 10,000 people.
Wow. That's terrific though.
Yeah, it is. It is. It's just the reporting. I didn't think that all the way through when I made it.
Right.
It's a lot.
I'm going to send this link to you guys individually.
Okay.
Just grab it, whatever. That's the one I made for someone else. And so they're just talking, and then she was in a blank room, and then I put the music behind it.
Oh, wow. You're very fancy.
Very fancy.
Quite the editor.
I'm always trying to get my kids to show me some of these things. They're like, oh, Mom, you're not going to be able to do it. I'm like, well, that's not
You
true.
are too. That's ageism, and it's inappropriate.
I know. Well, there is a little bit of that once in a while going on.
You tell them that, you know what? I taught you how to use a spoon. So
yeah, that's
relax.
right. My son says the best thing he ever taught me that I was most happy about was the snipping tool, how to snip things.
Which isn't a good thing. Because she snips everything.
Yeah, I do. I love
and
it.
Then you can't edit it or change it.
No,
if it's a picture.
I sort of quit Facebook because it was just too much drama. And now I'm on TikTok with the children.
Oh, you are? Okay.
Yeah.
Yeah. Well, my kids always tell me only old people use Facebook anymore. It's not cool.
And angry people.
Yeah.
That's
oh
it.
My God.
And angry people.
Well, and I don't know about you. I'm never interested in other people's political views. I could care less.
Or what they had for dinner.
Yeah.
I was actually talking about that with my kids yesterday. The issue is Instagram is nice, but it's not very good for events. So if someone says, hey, we've got this, I don't know, book club or bake sale on Thursday the 17th. Well, in Facebook you can save it, but in Instagram you can't.
Right.
If the children put it on Snapchat, it's gone in 24 hours. So Facebook still has a usefulness to it that the others haven't really.
What about, I haven't gone on TikTok. So
yeah, that's not useful for events.
No. Okay.
I mean, if it is, I haven't figured out how to do it.
Because it's quick stuff, right? It's just quick.
Yeah, I think videos can be up to 3 minutes, but most of them are much faster than that.
Oh, they are. Okay.
Yeah. Yeah. You know, yeah, who has one? She has her own channel now. Tipa Snow has
Okay,
her own channel. And because I use my TikTok account to kind of detach from work and
right.
the world, like I don't want to see those. I want to see like, you know, silly videos of I don't
Little
know,
kids dancing.
skiers or yeah, I tend to get a lot. Oddly, I get a lot of dairy farming videos. I have no idea why.
Really?
Yeah, like a lot of Iowa dairy farmer. It's so weird. The algorithm is super weird.
That is definitely different.
All right. So should we let these people in?
Sure.
Sure.
All right. Who's main? Are you both presenting?
Amy.
Amy. Okay. I gave it to both of you in case I lose connection.
Okay.
Afternoon, friends. We have a couple of minutes before we get started, but I figure we can welcome each other and as if we were meeting in a real space and see each other's faces if you've got your camera on. All right. It's a gray day in southern New Hampshire.
Same here.
We have probably about 50 people that will be on our call at some point. So if you haven't yet, go ahead and mute your mic. You're welcome to unmute it if you want to participate in a discussion or type in the chat panel. Happy to have people be engaged, but 50 would be a lot for background noise. I'll check out my chat panel. In the chat panel, I wrote, where are you logging in from? So if you can find your chat panel, you're welcome to participate that way and tell us where you're at. See some familiar faces. A lot of folks might have participated in the volunteer education day that we had a bit ago, or we have direct care providers, home care providers. Thanks, guys. We've been doing these webinars with Catherine and Amy since long before COVID. I think we've gotten really good at them over the last nearly 3 years.
We have.
Right?
Definitely. It's been a
Compared to when we first started with Zoom and Teams and Google Meet and
we used to do GoToWebinar. It had its own kind of challenges. But it had some nice things to it too.
Yeah,
the nice thing about
GoToWebinar, we like it. And they
I like GoToWebinar. If you're going to do breakout groups, though, GoToWebinar doesn't have that feature.
Yeah, right. But
they
just upgraded so the GoToMeeting is very much now just like Zoom.
Yeah, I figured once they brought in breakout groups,
right,
we would.
Now with all the competition too, I think they had to.
Right, so it is 2:00. I'm going to keep looking at that participant panel and let in other people as they come, but I don't want to keep anybody waiting. This program today, Communication and Responding to Challenging Behaviors, is module 14 in our multi-part New Hampshire Dementia Care Training program. All of these recordings are housed on a website that's available to all of the members of the Home Care Hospice and Palliative Care Alliance of New Hampshire. If your agency isn't a member of the Alliance, we'd love to give them information on how to become a member, and they can access all of those trainings that keep us in compliance with RS 154 that requires dementia care training throughout a person's career. Today, Amy Craven and her assistant Catherine Vanderhorst are going to be our presenters, and we'll let you take it away.
Good afternoon, and thank you for joining today's webinar. And also, I would like to thank Hospice, Home Care and Hospice and Palliative Care of New Hampshire for sponsoring this event, as well as Leslie for organizing and getting everything running smoothly. So today, as Leslie said, we're going to talk about communication and responding to those challenging behaviors that we often see with our loved ones or clients that have dementia or a dementia-related diagnosis. So today's objectives are to understand what may trigger the challenging behaviors, describe what you can do to help avoid those behaviors, and then explain how to communicate effectively with your clients and loved ones. So this is a quote from an individual who had early onset Alzheimer's, and I thought it was very effective. It talks, what she says is, give us time to speak. Wait for us to search around that untidy heap on the floor of the brain for the word we want to use. Try not to finish our sentences. Just listen and don't let us feel embarrassed if we lose the thread of what we want to say. And that's so true for individuals. We're always trying to do things for them, or when someone has a cognitive disorder, or are we trying to finish their sentences or say things for them? We had a patient one time say to us, if everybody would just give me the chance to talk, I can still talk. But nobody in her house where she lived was giving her that opportunity. They were all talking over her, talking for her, telling her what to do, bossing her around. And she made the comment to me one time that everyone's my boss and they're all my children, which I thought was interesting. What is communication? It's everything we do and say. Words make up a small amount of what we actually communicate. Think about what we do non-verbally. And that makes up a lot of what we say to others. Our body language, the way that we're standing. Do we have our arms crossed? Do we have our hands on our hip? Do we have a disgusted expression on our face? The facial expression that we have can portray a lot to the individual with a cognitive disorder. Although they may lose their memory, they still can read emotion. Do we present in an erect, stiff posture, or are we relaxed? Are we using eye contact or not? We're not even looking at the person we're talking to. All those things can make a difference. And nonverbal communication really makes up most of what we say. So how we walk in the room, how we approach an individual has a huge influence on how they're going to respond. Think of someone who has hearing issues. They gather most of their information from body language. They may be reading lips. They may hear a little bit about what you're saying, but your body language really says a lot. What about you? Let's say you just got a speeding ticket. You walk into your family member, or your client's home, and you enter the house, you're late. You're mad because you got a speeding ticket and you were only going 5 miles over the speed limit. Your face shows that you're upset, that you're rushed, and they can read all that, and it's going to get them upset. You're thinking about how much that ticket's going to cost, how your insurance is going to go up, and they read those expressions on your face. So we have to be very aware of that with individuals. When we're communicating, we should use 3 steps. Always call the client by name and tell your client or your loved one your name. They may not remember. Hi, I'm Amy. I'm your youngest daughter. I'm here to help you with getting ready today, Mom. Or, hi, Mrs. Smith. I'm Suzanne. I'm your caregiver today. Even if you were there yesterday and every day the week before, by introducing yourself and telling them your name, you help to save face because they probably don't remember. And then make sure that you're making eye contact with that individual. Come down to their level, talk to them, but keep the message simple. Don't give complicated instructions. I listened to someone a few weeks ago, a wife telling her husband what he needed to do. And she said, John, you need to go to the bathroom. You need to get your teeth brushed, your face washed, go to the bathroom. Make sure you put on the pants that I have laying over the tub. Do this. And he just looked at her with this confused expression. It was too much information, too fast. He had a cognitive issue, and he just stood there. He didn't do a thing. Instead, she should have said, John, why don't you go in the bathroom and start your routine? And she could have gone in there and helped him and given him one step at a time. We always want to use the positive rather than the negative. Oftentimes you'll hear caregivers or family members say, I want you to sit down, stop walking around, or don't do that, sit down, or go do this. And they say it in a tone of voice that's not respectful, and can be somewhat demeaning. Instead say something like this: I could use your help with putting the dishes in the dishwasher or on the table. I know you do such a great job. Use those positive statements. Or trying something like, oh, you know what? If you could, let's go get you ready, and then we're going to go out for lunch at your favorite diner. You're intertwining that positive. But again, simplify what you say, avoid questions, tell them always what will happen in positive terms. Using the diner example again, oh, you know what, Sally, we're going to your doctor's. And then after that, we're going to go to lunch to your favorite diner, or we're going to go stop for coffee, or we're going to go for a ride. Always bring in that positive. Break things into small cueing. Don't give that long drawn out explanation. Always simplify what you're going to say, and maybe use verbal as well as nonverbal cues. Tap them on the shoulder, put your right arm in the shirt, then tap them on the left, put your left arm in the shirt. Now let me help you button it up. And break those tasks into baby steps, giving one at a time, not all at once. I can't emphasize that enough, but always speak to them as adults, not as a child, even though their cognitive age might be that of a child. We always talk to them in a respectful voice and treat them as the adult that they are. Use that nonverbal communication, hand motions, facial expressions, modeling behavior, showing them what you want to do so that they can follow along in case they've forgotten how to do it. Excuse me. Communicating, we want to speak slowly. Be aware of their hearing and vision problems. If someone tells you, oh, you know, I never could hear out of this ear, or you read it on their chart, on their plan of care, always try to talk to them on their good side where they can hear you. Stand on that side, sit on that side, so they're more likely to be able to interpret what you're saying. If they have vision problems, are you making sure that you're in their visual field, that you're not way out to the side or behind them? Be in front of them, be at the level that they're at, so they have eye contact with you, can follow what you're saying. Forget reasoning. You're not going to make them understand. Their brain doesn't work the way yours and mine does. Their executive functioning, and their reasoning is not there the way it was in the past due to the changes in the brain. And don't say, don't you remember? Because they don't. And they're not going to, and you're going to get them frustrated. Avoid quizzing them, because that also can increase the frustration. Don't argue or try to reason. You won't win. You'll never win an argument. And then remember that 60, 90-second rule. For those of you that have never heard this, I went to a class years ago and they talked about the 60, 90-second rule, that people in the middle to late stages take 60 to 90 seconds for their brain to process a one-step command. And I took it with, I listened, I thought, I don't know if that's really so. I looked it up. There is some research on it. And my father had Lewy bodies. And one day he was a tall guy and he went down, luckily like a feather, did not get hurt. And he usually fell in the bathroom. My mother would call me and I'd go over there, try and use proper body mechanics, help pick him up. He'd sometimes say a few choice words or push my hand out of the way. And the one day I had one of my boys with me who at the time was 13. And he said, "Oh, Mom, I'll go help you get Papa up." And I said, "Okay." He goes, "It's all right if I'm a few minutes late for school." And so we went over there and he said, "Let me get him up." And at the time he was about 6'4", so he's more than capable. And he said, "I'll do it. You don't have to be in here with us." So I stood outside the door. I was a little nervous about the whole thing. And he said, "Papa, put your hand here." And then he waited and he waited. He's a teenager. He wasn't in a hurry to do anything. And then he said, "Put your other hand here." And he waited and he waited. They were in there about 5 to 7 minutes. He never laid a hand on my father. My father got up completely independently because he gave him those simple instructions. He gave him time to process those instructions and to do things on his own. So we need to teach families and caregivers to try and give the individual who has a cognitive disorder that time to process what we're asking them to do. And it gives them purpose and meaning because they can still do things. It's hard because we're impatient. We want to get things done. We have schedules to keep, but giving an individual with dementia that opportunity to process and do things on their own can be very meaningful to them because they feel like they're still participating in life. Another example I'd like to give you is we just recently had a client and the particular caregiver that was in there was constantly arguing with the wife. So there was a husband and wife, and they both have Alzheimer's, a type of Alzheimer's or dementia, living at their house. They have 24-hour care, 7 days a week. And the one main aide was constantly arguing with the wife. The wife was very difficult at this point. She argued back. And it wasn't a good situation. She was smoking, she was drinking, she was smoking marijuana, and so was the husband. And they said they've been doing this all their life, which is their choice. But this aide was constantly arguing with them, and it just escalated things in the house. The wife was always screaming. I went to one of their neurology appointments with the wife, and she, lied through the whole appointment with the neurologist. And we tried to get a new caregiver, the family to hire someone different. They got a new caregiver in there and it was like night and day. The house is calmer. The wife isn't as nasty. The drinking has decreased and the smoking. They're making soup together with this new aide. They're participating in things. So don't argue because it just escalates the situation. And it can really make a difference to be calm, use that calm voice, quiet voice, relaxed body language, and you're going to get a lot further with individuals with cognitive issues. So what are some of the techniques that we can use for communication? We want to validate and focus on what they're saying. So give meaning to what they're saying. If they say something, don't argue. They don't remember. Their reasoning or their reasoner is broken, as some people say. Mrs. Jones, I can see how upset you are. Tell me what happened. And then give them time to explain. Sometimes that will de-escalate the problem. Other times they may get more excited about it. and agitated. So you want to back away, maybe walk to the other room, give them some time to calm down, come back, distract them. What about therapeutic fibbing? What do we mean by this? So Mrs. Jones says, "Where's my husband, Ray?" And you know he passed away 4 years ago. Well, he's not here right now, or he went out. He went out in a big way, but he went out. You don't want to cause that catastrophic grief reaction again. So you're better off to say, "Oh, he left. He's not here right now." Sometimes that therapeutic fibbing or white lie is going to be more effective in those type of situations. So we always suggest using the 4 R's when dealing with challenging behaviors. So you want to reassess and figure out what's causing the behavior, and then redirect and focus their attention elsewhere, and then reassure. Give them a hug. Tell your client you understand, or your loved one, "Let me help you. I'm here to help you." And then reconsider, how hard is it for your client? Use empathy. Put yourself in their situation. How would you feel if you didn't understand what was going on around you? We had a private client recently. The family called us in to help. She had fallen at her house, actually at her daughter's house that she just moved to a few weeks ago. Then she went to the emergency room. She was in observation for 3 days in the emergency room. They admitted her on day 4. She had surgery. She went up to the 9th floor on day 5 after the surgery. And on day 7, she went to a rehab facility. And she was very, very confused at this point. The family asked if we would go in, help, see what we could do to help the situation with the transition. And when we walked up to her and introduced ourselves, she said, "Where am I? What am I supposed to be doing? And what am I doing tomorrow?" And I thought that said it perfectly, because she had no idea what was going on, why she was where she was, who people were. She was just so confused from all the changes that had taken place in such a short period of time. So what's really going on when we look at reassessing? Is there a reason for the behavior? Is there something that happened? Was it someone's approach who came in the room? Is it all the stimulation that's going on, all the noise? Is the radio on and the TV, and there's conversations, and there's busy wallpaper and busy flooring? Are they just frustrated because they can't do something? Are you asking them to do something they've never done? I was helping out at a rehab, and I tried to get this gentleman on a recumbent bike, and he got very indignant. He was not getting on this bike. He got quite nasty. Okay, so we did something else. He had recently been transferred there after some surgery. And I ran into he and his wife later in the hallway. And I said, "Well, I tried to get, Sam on the bike today, the recumbent bike, and he wouldn't have anything to do with it." And his wife said, "Well, he never rode a bike. He rode horses. He grew up on a farm. He never had a bicycle." Well, that made sense. So are we asking them to do something that's not familiar or that they've never done before? Are they uncomfortable about the situation? Are they in a strange place? Are there people they don't know and feel uncomfortable with? Is there too much noise, too much activity, too little stimulation? Are they just bored? They're just sitting there. Or are they in pain, hungry, thirsty, need to go to the bathroom? Always look at the physical first. Pain is the #1 cause of challenging behaviors, and people that are in the middle and late stages cannot verbalize that they're in pain and that they're uncomfortable. So we want to be aware of that. Are they fidgeting? Are they not willing to lift their arm like they did yesterday? Are they not willing to put weight on? Or are they just grimacing like they're uncomfortable? And can we address that? Can the family make sure that they're getting their over-the-counter Tylenol or Motrin or whatever they're used to taking before they're bathed, so that they're not, so uncomfortable and having those challenging behaviors? Pain is actually the number one cause, as I said, of challenging behaviors. The caregiver's approach is also up there. So we need to look at the physical and then the approach first. How do we redirect them? Give them something else to do. Can they fold clothes? Think about if they're in that stage where they're repeating themselves or doing the same activity over and over and over. Could we give them a repetitive activity to do? Could they fold clothes, straighten magazines, separate kitchen utensils? We worked with a family every day. They'd empty the silverware tray, have mom put it back in. She didn't remember that she did it the day before. She felt like she was doing something useful, and it got rid of that repetitive question she was asking her daughter throughout the day for a short time. Separating nuts and bolts or screws and nails, widgets, pushing in chairs, wiping off tables, sorting coins, sorting costume jewelry, giving them a jewelry box to reorganize, emptying their purse, or having them reorganize their wallet, folding napkins. All those can be great activities. Building with Legos. Redirect them into an activity that's something that they enjoy based on their life story. Reassure clients and loved ones. They live in a world that they no longer understand. Things around them have become confusing, not familiar. They may be in the house that they lived in for years, and it may not appear familiar to them. We had a client recently tell us, brought mom over to her house, the daughter and son-in-law, and they're sitting in the driveway, get ready to get out of the car. And mom says, "Oh, this is a lovely house. Whose is this? Where are we?" And she had watched the daughter's children there for 20 years after school, and she didn't recognize the house. So that happens. We need to reassure them. They need hugs, they need touch, they need soothing words. Hold their hand, rub lotion on their hand, give them that human touch. They need to be offered comfort and assurance that everything is okay. Things around them are becoming so confusing, things that they used to understand. And always remember that their memory may be gone, but they still have feelings, even though they can't express them. So what do we mean again by reconsider? Try to see the world from their perspective. Think about how you would feel in their situation. Everything is confusing to them. Everyone they see may appear as a stranger, even people that were familiar. Yet you're in there and you're doing personal things to them. You're helping them bathe, you're helping them toilet, and you're a stranger. I don't know you, and you're going to help me with this. That's very overwhelming and confusing. They may be a modest person and don't understand why someone is doing this to them. And they no longer recognize family members, or maybe you've been their caregiver for a year. It doesn't matter. They may not recognize you. That's why you always introduce yourself. Wear a name tag. In the late stages, they may not even understand what we're saying to them. They hear the words, but they're unable to interpret what they mean, or they're not getting the message clearly. They may not be hearing what you're saying. So how do we respond to some of the specific challenging behaviors? We talked a little bit about the repetitive they ask the same question over and over again, redirect them, take them on a walk, give them something to eat, a snack. Playing music can be very effective. Remember, music isn't stored in all parts of our brain. So all the way to the very end, music can be effective. Sing a song with them that they like. Play music from their generation that they enjoy listening to. Sometimes making up a song to describe what you want them to do can be great. I won't give you an example because I can't carry a tune, but using a familiar tune and then putting words to it, maybe to get them up and get them dressed, or to get them in the shower, making it more entertaining, making it more fun. And then giving them that repetitive activity to do, like the silverware or sorting buttons. We had a client that's her daughter and son-in-law had this big container of buttons of every color and shape and size. And some days they'd have her sort them into colors. They'd just dump a handful of them out. Some days she'd sort them into size. So finding things, she was a seamstress at one time. So it was something that was familiar to her. So finding familiar things for them to do. Another great thing that helps is if they're in the early stages and they can learn how to use something like an Alexa or a Google Home, instead of asking their daughter or their son-in-law or their spouse the same question 15 times, you can say, ask Alexa. Alexa can tell you the weather, or Alexa can tell you the day or the time. And that can be a lifesaver for families. I know we did this with my own mother. And you could tell sometimes she'd just be getting frustrated about things. And she'd say, Alexa, play Frank Sinatra. And she'd say the name of the song. And then as the disease progressed, she couldn't remember the name of the song or the artist. So we made a big whiteboard for her wall, a big poster board with her favorite songs and the artists. So she could still ask Alexa because she could read the words. And that can be an activity. They can play trivia. You can play Jeopardy once a day. You can do the question of the day. Even though they don't get the right answer, it's okay, but it gives them something repetitive to do. What about hallucinations? Oftentimes, this can be very frightening, not only for the individual, but for the caregiver, because how do you respond to this? You always want to report it to the case manager or the office and make sure that the client, it can be either auditory or visual. So make sure that they have their hearing aids in, that the batteries are in, and that the hearing aids are working. And or do they have their glasses on? Do they have the correct glasses on so that they can read or they can see in the room, not their reading glasses when they're looking across the room, or their bifocals when they're going up the steps. You've got to be careful of those things. If it is scary, reassure them, tell them you're there to protect them and keep them safe. Oftentimes it can just take shutting the drapes or the blinds or the curtains and turning on the lights so that they're not seeing those shadows. And the most common time we see these are usually with Lewy bodies dementia or Parkinson's dementia. Other types of dementia, we do see the hallucinations, but those are the most common. And with Lewy bodies, they often see small animals or small people, and they're usually not scary. If it is pleasant and it's not scary, just go along with it. Oh, okay, I'll shoo those under your bed now. They're gone. Go along, don't question them. Sometimes you can say, well, I don't see that, but describe it to me. Just tell me what you're seeing. It's just easier most of the time to go along with the hallucination if it's not frightening. Redirection, making sure they're in a well-lit area, minimizing the shadows, as I mentioned, and then being with others, getting a conversation going, talking to them. They'll forget. You're redirecting them into a different area, into a conversation, or moving them into a different area of the home. getting them out of that room and moving them into a room that has better lighting, brighter lighting, so that they're not having issues. If they continue, as I said at the beginning of this slide, I just make sure that you do report it. If this starts to become a frequent thing, and it is frightening, especially. So how do you respond to sundowning? Sundowning can be very challenging for families and caregivers. We often see increased agitation, anxiety, disorientation, confusion in the late afternoon and evening. It may be expressed by crying. They may be very active at that time of day, or they may be very unactive, very lethargic and not want to do anything, be difficult. It's different for everyone, but we want to reassess. Is it the stress that's going on throughout the day? Are they overtired? I always think of small children. When my kids would come home from at the end of the day, either from school, or I'd pick them up after work, or my husband would bring them home, I always call it the horror hour. When you're trying to get dinner ready, they're hungry, they're tired, they want your attention. Is it the same type of thing? It could be. They really don't know what causes it. Are they just bored? Or is it the overstimulation? Or are they so tired from the whole day that they just don't know what to do, so they get agitated? Sometimes moving them to a quiet area, offering in a movie or a snack, redirecting them into an activity. Could they toss the Nerf ball? Could they do an activity like sweep the floor? Or could you give them a baby doll to cuddle or to care for? Or the Joy for Life animals for seniors, and I'm not endorsing them, but those are wonderful. If you've seen them before, they actually turn their head to the voice in the room. You pet them and you can feel their heartbeat. The cat meows, the dog makes a little barking noise. They're very calming. Reassure that your clients or your loved ones, don't argue, and look at things from their perspective. There's actually been research done that shows that using natural lighting can help to decrease sundowning, using things like the Joy for Life animals, live animals in the room. We were looking at a facility for a family in the Albany area, New York area, and we had a scheduled tour of this facility, and we went in there and they said, well, we don't normally let people in between the hours of 3 and 5:30. I thought, well, that's kind of strange. But they did have animals that lived on this unit. In this dementia unit, they had 2 cats and 2 dogs. And they were there in the room. They had the lights bright in this room. They had music playing that was very calming. We were told we could do this tour, but we weren't allowed to talk to anybody. They had some drinks out. They had some snacks out for people. And it was the calmest dementia unit I've ever been in. But every day between those hours, they had what was called quiet time. Some people were in their room, a lot were in the great room. They had little activities going on for people that were interested. There was one gentleman working on a puzzle. There was another woman who was, an aide was helping her paint her nails. So it was very calm, very quiet. And they were able to reduce their sundowning substantially, the behaviors. So what about if someone does get agitated and aggressive? If you do feel at all threatened, you want to protect yourself, retreat, always report any episodes of agitation or aggression to the case manager or the office. But try and prevent it by having people in that calm, quiet environment use the same routine, soothing rituals at the time of the day where they're agitated. If it's always at 3 o'clock, then find something soothing and calm to do at that time period. Are they in pain? Are they hungry? Are they thirsty? Do they need to go to the bathroom? Are they overtired? Could they have an infection, a urinary tract infection or another infection? And then again, simplify the tasks and allow them time to rest between activities. Don't expect individuals to go from one thing to the next. Give them a little rest period. Maybe you don't want them to sleep in the afternoon, but give them some time to just relax, rest, maybe put on some calming music that they like, and then start the next activity 15, 20 minutes later. And try to identify, look back, what could have been the trigger to that agitation? Is there something different going on today? Let's say you're a caregiver that comes in the house every morning at 8 o'clock. You start with this individual and you come today and you notice your client is very agitated. What's different? Maybe there were visitors in the home. Maybe the individual's spouse left early and left him alone and they weren't used to that. Or the spouse was rushing around to leave when you got there. Could that be the trigger? Or are they in a different room? Are they not sitting in their normal chair? Did they get something they don't like for breakfast? It could be any of those things or a multitude of other things that could be causing, but we want to look for those triggers. What's different? What could have caused the behavior? And then how do we respond if they are agitated? You want to get their attention and redirect it to something else if you can. Don't crowd, don't get too close to them. Use calming statements, a calming voice. Reassure them, slow down, maybe brighten the lights in the room. Focus on pleasant events. Oh, Sally, tell me about your visit that you had yesterday with your grandchildren. Change the situation. Don't raise your voice. Don't take it personally. Don't corner the patient or crowd, like I said. Don't restrain them. Don't rush them, criticize, or ignore them. Don't argue, don't confront or try to reason or shame, demand. Don't be condescending. Don't be forceful and bossy. Don't try to explain. Don't show alarm or shock or move suddenly in or out of the client's view. You want to remain calm. Can I help you? Or redirect. Do you have time to help me with getting breakfast ready? Could you maybe put the silverware on the table for me and get some napkins out? You're safe here. Everything's okay. It's under control. Apologize. I'm so sorry that you're upset. I know it's hard. I'll stay with you until you feel better. Be reassuring, be calm. So if they're very aggressive and agitated, verbal agitation can often escalate into physical. So we want to be careful, try and manage that and avoid it from escalating. We want to diffuse it before it gets out of hand. Always agree with them. Apologize. It's hard to argue with someone who's contrite. Play dumb. I don't know how something like that could have happened. Tell me more about it. Try and buy calmness. Don't reason, don't explain, but always keep your distance. Keep your back between your patient and the door so you have an escape route. If they do get physically aggressive, you want to protect yourself and others in the home. Suspiciousness. You don't want to take it personally. Don't argue or try to convince otherwise. Always just offer a simple answer. I wouldn't do that. Redirect their attention to something else. Let's say you walk in the house. Catherine had a patient years ago that she accused everyone of stealing her olive green pans. Oh, I'm sorry that you lost your pans. Can I help you find them? And then after a few minutes, begin to distract. Oh, let's go get a cup of coffee in the kitchen and keep talking. Or they accuse you of stealing their purse. I'm sorry that you lost your purse. Can I help you find it? And then in a few minutes, oh, let's go get a glass of water, or let's get ready to go, for a walk. Keep talking and then distract. What about inappropriate sexual behavior? It's more common than you think. A lot of us have seen this with our clients or patients in the field. You want to evaluate it because a lot of times it isn't sexual. Someone's taking their clothes off. Maybe the clothes aren't comfortable. The individual may be responding to the tags in the clothes that are uncomfortable. Maybe it's a new laundry soap that irritates their skin. Maybe the clothes are too tight, or they need a larger size. Oftentimes we see people that were living alone and with a cognitive disorder weren't really eating well and not preparing good meals. They were maybe snacking, and now they're either living with a relative or have moved into an assisted living or congregate living situation. And now they're getting 3 meals and snacks, and they've gained all this weight. Their clothes don't fit anymore. Or I had a client years ago, we went out to see when I worked in home health care, and she had been taking her clothes off, disrobing, and her daughter was so upset. She just moved into this assisted living facility a few weeks ago. And she said, my mother was always so modest. She never even wore V-necks. She wore turtlenecks, high neck shirts. She was very modest. I don't understand what's happening. Started talking to her, finding out things. Well, mom had to go out and purchase sweatshirts and sweatpants for her daughter, she said, or for her mother. The daughter had to go out and purchase those things, Velcro sneakers, everything that was on the list. I did just what they told me. And we said, well, she didn't have sweatpants or sweatshirts? No, my mother always wore a dress. So we suggested she go home, get those dresses. Mom never took her clothes off again. She was in unfamiliar clothes. We had another gentleman that lived in an ALF. He was a retired physician. He was doing the same thing, taking off his sweatpants all the time. He had been used to wearing a suit with a belt. His son brought in his suits and his pressed shirts. He could still tie his tie, and he walked around looking quite dapper in this assisted living facility, and he never took his clothes off again. So it's what's familiar to them. It might be that they've never worn those type of things. Are they urinating or defecating in the wrong place? Maybe they can't see the toilet seat. Everything's one color. Or they don't know where the bathroom is. They're living in a relative's home or they've just moved to the assisted living. They have no idea. Could we get permission to put up a picture of a toilet and a word that's familiar to them, whether it's bathroom or latrine or head, so that they can find that room? And think about what you would do or what you have done if you walk into your client or your loved one's house and they're masturbating. What are you going to do? Excuse me, let me know when you're finished. We went in an assisted living facility about 2 years ago before COVID, and they had little do not disturb signs that they'd hang on the door. If someone walked in, give them their privacy, let us know when you're done. But think about, what do young children do when they have to go to the bathroom? They hold themselves. Maybe they need to go to the bathroom. Is that what they're trying to tell you? But what if it is sexual? What are you going to do? You want to make sure, again, your facial expression, don't show them that you're upset, because just like a small child, if they're getting a rise out of you, they're going to do it again. They may be making inappropriate comments to family, staff, or others, or touching inappropriately. We want to calm ourselves any way we can. Do some yoga breathing, say a prayer, count to 10. Whatever you do that you can calm yourself, because you want to control that nonverbal reaction. I don't like it when you talk to me like that. Don't yell, use a calm voice and repeat that as needed. And make sure that you're telling everyone else who's seeing that client or working with that individual, so everybody's portraying that same message. Remove their hand if they touch you inappropriately. You can't touch me like that. Please don't do that. Sometimes they need a medical consult. That's the worst case scenario, because you can't restrain people. You can't use overalls or aprons or things that you could do in the past, especially in assisted living at home. If the family wants to use those type of things, they can. We had an individual who was going into clients' rooms all the time. The sweetest little guy. He was crawling in bed with women. All these things were going on. Families were getting quite upset about it in this ALF. So they tried, and this was years ago when you could put someone in overalls or put an apron on. They tried that. It didn't work. The doctor tried some SSRIs, which can decrease your sexual libido. That did not work. And they eventually ended up using some hormone therapy, and that worked. So that's the worst case scenario. So if they, you're not able to control those things, they may need that medical consult, but not very often. I want to thank everybody for spending some time with us today. Are there any questions or comments or things you'd like to share about your clients or things that have worked with dealing with challenging behaviors with individuals that you work with frequently?
We have some time. If people want to type in the chat, I really appreciate all that you went over in the last hour, Amy. Thank you. Any other case studies people have had experience with they want to share? Just have to unmute your microphone and Zoom should be able to pick you up.
Any challenging clients that you have right now or family members and you're not sure what to do? Or do we have a quiet group today?
That happens. If I don't want to keep people either, so if there are no other questions or comments or case studies you folks want to go over, we will end it here. I will send you all, here we go. This is the link to the quiz for module 14. You'll also find that on the nhdementia.com training site, which you all have access to. But I also have that SurveyMonkey up. Guy Tillison has an interesting comment. He's concerned that sorting buttons, nails, screws, and things like that could be a choking hazard.
And you'd have to be careful. It would have to be with a patient that you weren't afraid or fearful that they would do that. So with those type of clients, I might use something bigger like the silverware or sorting tools in a toolbox, things like that can work. And one of my favorite things to do is have people empty the dishwasher, because it's a great balance activity, because they're stepping, they're moving, they're unweighting on one side, using head turns, things like that, or setting the table, rearranging their closet. Those can be repetitive type behaviors that can work. If it's something that they're willing and to enjoy doing. I had a client once tell me, I've never done this and I'm not going to do it. I've never emptied the dishwasher. Okay. Well, not a good activity for that individual, but he would sweep the floor. So finding what works with that individual, but that's a great point. Thank you for sharing that. You want to always be careful that it's not a choking hazard.
My grandfather had Alzheimer's disease and he had a similar one. They wanted him to do yoga and I didn't have yoga, but I didn't do yoga before I had dementia. He actually had a different dementia, but like I'm not starting now. Like good, all right, fair enough. Fair
And,
enough.
and people remember those things that I've never done this. I'm not.
No.
I had a patient years ago when I went in for a PT referral, and he said, "I've never exercised, and young lady, I'm not starting today." I'm like, okay.
Fair enough. They did, not that it's useful for everybody, but the assisted living place that he was living, they got him to volunteer at the North Springfield, Vermont transfer station. So with, early and middle stage dementia, he sorted plastics.
Oh, that's great.
Yeah, and everybody knew him because he was the history teacher for the elementary school for 45 years. So they would come up to him the entire Saturday and, "Oh, Mr. Clement, how are you?" And yeah,
That's
it
a
was
wonderful
his social
story.
hour.
Yeah, because
I don't know if he did it very well, but
it doesn't matter. It gave him some purpose and something
Yeah.
to do. Yeah, and familiar people, and
Yeah.
that's a great story. Thanks for sharing that.
All right.
Anybody else have any great things that they've done with their clients that they want to share?
All right, this video will be posted probably within the hour or two onto the training site, and I look forward to seeing you all next time.
Thank you for your participation.